Receiving a new organ, it feels like an absolute miracle. But the wildest part? The real challenge actually starts after the surgery. How do you convince your own body not to destroy this incredible life-saving gift? Well, the answer is this delicate, lifelong balancing act, all managed by a powerful cocktail of medications. So in this explainer, we're going to unpack the amazing science behind the drugs that make the impossible possible.
Okay, so right at the heart of every single transplant, there's this fundamental conflict. On one side, you have this life-saving new organ, and on the other, you have your own immune system, which is basically a super effective security force that's programmed to destroy anything it doesn't recognize. The entire field of transplant medicine is really built around solving this one single problem.
So here's how we're going to break it all down. We're going to follow the journey right from the moment of the transplant, look at those critical first days, and then dive into the lifelong strategy that's required to protect this incredible gift.
So how do you even begin to solve this conflict? Well, the entire strategy revolves around one key idea: immunosuppression. The best way to think about it is like you're negotiating a truce with your body's security team. You have to carefully and very deliberately lower its defenses just enough to let that new organ settle in.
And this right here gets to the core of the challenge. It's all about finding that sweet spot. So you can't just turn the immune system completely off. That would be a total disaster. The real goal is to dial it down just enough to protect the new organ while still leaving enough power to fight off actual threats like infections. This whole balancing act starts the second the surgery is over, and this first phase is called induction therapy. You can think of it as a really powerful initial wave of immunosuppression that's designed to protect the organ when the risk of immediate rejection is at its absolute highest. A major player in this first phase is a drug called basiliximab. It's what's known as a monoclonal antibody. And honestly, the best way to think of it is as a highly specific smart bomb. It goes in and it targets the immune system's frontline soldiers, the T cells, and it stops them from even getting activated in the first place. It's a preemptive strike, basically, stopping a full-blown attack before it can even get started. So once that initial storm is past, the whole strategy shifts from a sprint to a marathon. This phase is maintenance therapy, and it's a daily, lifelong regimen of drugs designed to keep the immune system permanently in that sweet spot of suppression. This is the multi-billion-dollar question, right? And the answer, it's not some single magic bullet. Nope. Instead, it's a whole team of drugs, and each one targets the immune response from a slightly different angle. By using a combination, doctors can use lower doses of each drug, which helps minimize side effects while building a much stronger, more comprehensive defense for the new organ. First up, we've got the calcineurin inhibitors. So these drugs work by cutting off the signal that tells the T cell soldiers to multiply. It's pretty simple. No signal, no army. Now, here's a fascinating and super crucial detail for patients. Something as simple as grapefruit juice can actually dangerously boost the levels of these drugs in the blood. So yeah, it's strictly off limits. Next up are mTOR inhibitors. These guys attack on two fronts. So just like the last class, they stop T cells from getting activated, but they also stop the production of antibodies, which are kind of like the immune system's guided missiles. So it's a really nice double-layered defense. Co-stimulation blockers. Now, these work in a really clever way. See, for T cells to launch a full attack, they need a second go signal. These drugs essentially block that second signal from ever getting through. Think of it like jamming the communication lines between the immune cells, which prevents them from coordinating an effective assault. Okay, now for purine antimetabolites. These take a totally different approach. They go after the supply chain. They actually disrupt the production of the DNA building blocks that new immune cells, both T and B lymphocytes, need to form. By limiting the supplies, they effectively shrink the size of the army that could even think about attacking the new organ. Then we have the IMDH inhibitors. These act like a roadblock. They literally prevent white blood cells from gathering at the site of the new organ. If the troops can't even get to the battlefield, they can't do any damage, right? And finally, we have corticosteroids. You can think of these as the riot police. They are super powerful, broad-spectrum anti-inflammatories that just calm everything down. Their main job is to lower the overall threat level in the body, which creates a much less hostile environment for the new organ to live in. But even with this incredibly sophisticated daily defense plan, sometimes the immune system is just too persistent. It can manage to break through that medication barrier, and that leads to what's known as a rejection episode.
This timeline really shows that rejection isn't just one single event, it's a whole spectrum. Hyperacute rejection, that's a violent, immediate attack, but thankfully it's pretty rare these days. Then there's acute rejection, which is a more common battle that can happen in the first few weeks or months. And finally, chronic rejection. That's like a slow, simmering war that can damage the organ over many, many years. So when acute rejection happens, doctors have to escalate their response. They'll usually start with a high dose of those corticosteroids to try and bring down the inflammation. If that doesn't do the trick, they bring in the heavy hitters. Antithymocyte globulin is like a broad-spectrum weapon that just destroys T cells. And for the most severe cases, there's muromonab CD3, which is more of a precision strike, a monoclonal antibody that rapidly finds and removes T cells from circulation altogether. But all of this incredible advanced science, it all hinges on one final, absolutely critical factor. The most sophisticated drugs in the world are completely useless if they aren't taken correctly. In this lifelong balancing act, the patient's role is everything. Just look at this number. Studies estimate that the rate of non-adherence, which means patients not taking their medication as prescribed, is somewhere between 2 and 68%. I know, it's a huge range, but the takeaway is terrifyingly clear. Simply not taking the pills is a major cause of organ rejection and ultimately transplant failure. And when you look at this list, you can see why it's so incredibly challenging. Patients are constantly trying to navigate this complex reality, taking the drugs to prevent rejection, but also managing the side effects of those same drugs, all while being at a higher risk for infections and often dealing with a huge financial cost. Success really depends on navigating all of these challenges every single day. The ability to suppress our own immune system with this kind of precision, it's a true medical marvel that has saved countless lives. But it does leave us with a final question. Is the future of transplantation just about even more targeted drugs? Or will we one day find a way to actually teach the body to accept a new organ as its own and get rid of this delicate, lifelong balancing act altogether?